All right, listeners, Happy New Year to all of you who stick around for Lit Matters. I am Drew, joined by the one and only Cam Berg. We are going to kick off 2025 with 3 fantastic articles talking about one of the things I like to do least in the emergency department, procedural sedation. I have been previously quoted on a different podcast talking about how it is an irrational fear of mine to do procedural sedation, and I am hoping that with these 3 articles today, Cam can not only give you all great education, but also provide a counseling session to me. Cam, let's kick it off.
Yeah, thanks so much. I picked these articles because I think procedural sedation, perhaps contrary to you, is awesome. And I think it's one of the things that we do that's the closest to magic, right? We genuinely can do anesthesia workflows in the emergency department while simultaneously fixing the problem that caused the patient to come in with. They then wake up, and frequently we get to send them home. So my hot take, Drew, is I love the procedural sedation, and I think it's really important that we pay attention to this literature because, as you said, it is not without its potential pitfalls.
Yeah, so Cam, my problem with procedural sedation is most of the time, not all the time, there are times that we do procedural sedation for a critical scenario. Like we have to do procedural sedation maybe for a cardioversion. Although arguably, if it's really bad, you can just cardiovert them and say, sorry that hurt so much. Sorry, right? Mm-hmm. But we're taking a patient who is otherwise healthy with maybe a dislocated shoulder or a fracture or something like that. Again, neurovascular compromise being the exception, but those are rare. And I am taking somebody to the brink of apnea and hypotension and sometimes bradycardia to do this thing that, well, it will make them better is by no means saving their life. The real issue comes into play in that, in my opinion, and I heard this quote from somebody else who is much smarter than me, there are 2 types of emergency medicine physicians in the world. Those who have had procedural sedations go wrong, and those who will have procedural sedations go wrong. There is nary a provider who will not have a procedural sedation go wrong at some point in their career. And the worst I had was a young, healthy farmer who had a trimal unstable fracture that needed reduction because of neurovascular compromise, or at least pending neurovascular compromise, that I sedated, caused him to be apneic, could not provide adequate bag valve mask ventilations, had to drop a supraglottic airway device in, all fine. He did okay with that and still could not reduce the fracture. Ugh. Insult to injury, yeah, but I digress.
That hurts. But at the end of the day, did he die?
No, he did fine.
Right.
He did fine.
He did fine. And you paid attention to all of the things that we're going to talk about today. And so that really is why I think it's time for us to cast a light in this somewhat dark corner of murky evidence in emergency medicine, which is to say, what are the right protocols, the right drugs, the right routes, the right doses, and the other things that you should keep in mind? Because this evidence space has actually moved quite a bit in the last couple of decades, and we're going to get into it today. And so to start off, we picked a systematic review, and this is a very nice piece of literature because it gives really kind of that 30,000 foot view on the entire ecosystem of emergency medicine procedural sedation, which of course is a vital tool in the emergency department. It's how we manage really bad injuries. It's what we do in the setting of really dangerous illnesses. And of course, we try to maintain all of the vital signs throughout the sedation. We know, of course, that different drugs have different safety profiles. And really, one of the primary takeaways that I think both of us would like to give the listeners today is there's not like one cocktail that you should have as your go-to. You should contemplate exactly what the patient's physiology requires in terms of support and the risk profile of different agents before you kind of embark on your sedation approach. Is that what you do, Drew?
Yeah, I think you have to really look at the patient and go, what's going to be best for them? Although we're going to talk about in Article 2 and Article 3 that maybe there's some combined approaches that take care of both of these things. But there are a lot of individual agents that on face value are perfectly fine for procedural sedation. But when applied to the specific patient, you have to be very careful about which one you choose based on those patient's risk factors.
Absolutely. And so with that, let's jump into article number 1. This is by Khan et al., and it is entitled Safety of Procedural Sedation in Emergency Department Settings Among the Adult Population, a systematic review and meta-analysis of RCTs. And this was published in Internal Emergency Medicine, kind of a funny journal, but it came out just earlier this year in August of 2024. It's a very fresh paper. And in this meta-analysis, the authors performed a review of all of the available literature regarding procedural sedation in the ED. And I think that's a really important distinction because oftentimes when we wade into this literature, we end up getting things from ambulatory surgery centers, or we get them from the ICU, or we get them from the OR. That is not what these authors used for this analysis. They really restricted all of their analysis to RCTs performed in the emergency department, which is why I love this. The authors here evaluated for adverse events, and they reported them in 4 different categories. And that's really important before we get into this. So they de facto, before they began their analysis, had subdivided adverse outcomes into the following categories: cardiovascular, respiratory, neurologic, and GI. And then they essentially are looking for the rates of these relative adverse events depending on the specific sedation agents used. And I think the takeaways are pretty pragmatic here. So understand that going into this, it's all ED trials, it's adult population, they needed to be randomized, and they had to report on adverse events. And now the authors superimposed our favorite thing here, Drew, PRISMA reporting guidelines. So this is here to stay. The 2020 PRISMA standards are alive and well. For those listeners who are confused by that acronym, we'll include a link back to a previous review of this methodology that Drew and I have gotten into. Suffice it to say, this is the state of the art for performing meta-analysis in 2024. If the articles didn't mention adverse events, they excluded them. If they had mixed populations, they excluded them. And they ended up, therefore, with a total of 32 different trials that met this definition. So that's a moderate base of evidence, but it's somewhat surprising to me, Drew, that there aren't hundreds or even thousands of these trials out there because, as we've said, this is something we do every day. Basically, anybody with their EHR could embark on a trial like this, which is a little plug to those young researchers out there. This space has some opportunities for publishing. Believe it or not, despite the frequency with which we perform procedural sedation, we don't have a whole ton of evidence here.
Yeah, it's interesting, although I think you nailed it initially, is that the literature for this is specifically emergency medicine based. It's not our anesthesia colleagues. It's not our critical care colleagues. It's not GI, cardio, whoever as they're doing procedural sedations. It's also interesting that I think only maybe in the past 5 up to a decade years have we seen this be a true independent practice for emergency medicine physicians ubiquitously across practice, right? So I can say that when I started, I'm a PGY 12 or something like that at this point, my primary location, I was always able to do procedural sedation with really any agent that I chose. At other places that I have worked, we were limited on what medication we could choose. In one place, it was really essentially benzodiazepines and etomidate up until recently where you could use ketamine or propofol. And I will tell you, that is not great practice. And so it's not entirely surprising to me knowing that at the true, maybe farther out community shops, that was the reality, particularly because of limitations put in place by anesthesia oftentimes, that there hasn't been more studies other than the ivory tower academic institutions or community academic centers where maybe we're allowed to do a little bit more.
Yeah, that is so well said. And that's a perspective that I've actually forgotten. Like you, I have had unfettered access to any agent in any route that I want throughout the majority of my career. If you're listening right now and you do not, if you just have a protocol that gives you a single agent, push pause, download this article, send it to your department, because at the very least, this should give you ample ammunition to say, hey, this is a complicated ecosystem. Emergency physicians are experts in this space, and we need access to the entire pharmacologic armamentarium. Otherwise, we're going to do wrong by our patients.
Absolutely. So Cam, let's get to the meat of this and tell me what they found as far as different agents we're using and good versus bad effects.
Yeah, so we're going to just do a very high-level surveillance of this. I think the granular details of the outcomes don't matter so much, but I'm going to try to give you some of these numbers to inform your gestalt. Because the next time you are consenting a non-emergent patient for sedation, it's really important, I think, that you contemplate what are the bad things that could happen and how likely are those to occur. So specifically, the authors are looking for hypoxia events, agitation events, hypotension events, and apnea events. And I'm just going to give you the high-level metrics for all of those so you kind of have those numbers in mind. Again, this is in the hands of our colleagues. Hypoxia occurred across this entire literature space in about exactly 10% of cases. Agitation occurred in about 2.5% of cases, hypotension in 4% of cases, and apnea in 5% of cases. So that means a little bit more than 1 in 10 sedations was beguiled by one of these complications. Now, of course, these are the complications that we look for. These are not exactly terrible things to occur, but they occur with relative frequency. So if you're going about this in a cavalier fashion, right, if it's just like, squirt the propofol, nurse, and I'll be in a few minutes, please stop. Because 1 in 10 times, you're going to have to do something that you didn't exactly anticipate going into the sedations. And now to kind of parse the different agents, I'm just going to break apart those categories. So in the cardiac complications, hypotension was by far commonest when providers were using sodium thiopentate plus opiates. Is that something you do, Drew?
No, and no again.
Yeah, so I actually think this is one conclusion that we can just ink right now. If you are using barbiturates for sedation in the emergency department, you should probably stop. They have adverse events occurring at about 3 to 4 times what we see in the setting of benzodiazepines or ketamine or propofol or opioids or a combination of those. So no more to the barbiturates. I actually can't think of a single reason to use them in sedation.
I completely agree. And to be fair, Cam, and I'm curious your take on this, I don't like opioids for sedation either. Very rarely, if ever, am I using them. And if I am, it's maybe for a shoulder dislocation where I'm not really actually doing sedation. I'm just looking for analgesia so that the patient is more compliant with the techniques I'm doing when I'm not doing a procedural sedation.
Yeah, that is going to be my takeaway as well. Opioids, for the purposes of sedation, you're really using the drug for its side effect profile, right? You're giving a mu opioid agonist in hopes that it makes the patient kind of sleepy and hypopnic. It's not exactly what we want. So I am going to agree with you. Barbiturates off the list and opiates are low on the list, but we are going to parse those outcomes so you can actually, have a more informed conversation about this. When we talk about respiratory complications, we're looking at a variety of different things here, right? Hypoxia is, of course, the primary thing that we're looking for, but also this study, because of its size, was able to parse out apnea, laryngospasm, and intubation. And so I'm going to give you, again, those high-level metrics there. Hypoxia occurring in about 10% of overall cases. It was highest by far when midazolam was used in isolation, and second to that was propofol. Actually, no big surprise for me there. Those are pure sedatives. We expect to induce some degree of hypoventilation. And without sufficient supplemental oxygen, hypoxia is kind of that leading indicator. So researchers here were using a variety of different hypoxia definitions ranging from 90% to 94%. The important thing is this was not a dangerous level of hypoxia, but please, if you're using benzos in isolation to get deep sedation, you should expect hypoxia to happen quite a bit. When it came to laryngospasm, that I would contrast as being kind of different than the apnea, hypoxia, intubation spectrum, right? Laryngospasm was, interestingly, most highly associated with etomidate And that occurred about 1.5% of the time. And I bring that up because that is a non-trivial rate, and I have for sure seen laryngospasm happen with etomidate. And so we sometimes think of etomidate as being this really hemodynamically stable agent, which it is. This trial found that it had the lowest rate of hypotension, but in exchange for that, you do have to worry about this kind of idiosyncratic laryngospasm response.
Yeah, Cam, I have never liked etomidate on its own, in large part because of that. I think it goes back to my training as a paramedic, and you were taught as you were inducing for intubation for RSI that etomidate was going to cause laryngeal spasms. Then you had to give additional etomidate or maybe a benzodiazepine to get the patient through, which is the last thing you want in a critical airway scenario. Also, one of the last things you want is you're doing a procedural sedation, because it's something now that you have to do acute intervention on, and makes that airway management that you're trying to avoid the entire time much more difficult. There's some other things about etomidate that we can tease out later or save for another episode that I just don't love. So, while it is not as low on my list as barbiturates, which are off, and opioids, which are the bottom, it's still very low on my list.
Yes, yeah, totally agree. And so on the flip side of the benzos and propofol and etomidate, all of those kind of emerging as higher risk factor for the respiratory complications, the most respiratory stable agent in this trial was very clear, and that's ketamine. So ketamine had by far the lowest overall rate of hypoxia and apnea and need for intubation. I think that is not surprising. It has a fundamentally different mechanism of action. It does not result in so much hypoventilation, and so it's nice in that regard. But as we flip to a different outcome, the neurologic outcome, really what the researchers were looking for was agitation. And now agitation can occur to a variety of different reasons in the setting of sedation. It can occur during induction. It can occur during emergence. Overall, ketamine, not surprisingly, had the highest rate of agitation. To give you the number, it was about 6%. That's not trivial, right? That's like, 1 in 15 patients is going to have some degree of agitation. It is, of course, manageable, but it's something you should look out for. On the flip side of that, propofol, pure sedative, had by far the lowest rates of agitation at about 1%. I think no surprise to me on either of those things. And the final category of outcomes are what we're talking about, gastrointestinal, which is largely vomiting and the consequence of vomiting, which can be aspiration events. Very similar, again, to what I think you would expect here. Ketamine had the highest rate of GI adverse effects. Those were principally vomiting, not aspiration. So, it's not great to vomit, but it's also probably okay as long as there aren't complications from it. And that occurred in, again, roughly 6% of cases. So while ketamine is very, very stable hemodynamically and from a respiratory perspective, it has relatively higher rates of adverse effects in the neurologic and GI categories.